Recording for EKGs. This goes along with chapter 29 in your textbook. First slide is just showing you a review of the anatomy. We talked about like blood flow with the bell ringer quiz last week, so this is a review and you'll want to know how blood flows through the heart, where the valves are, and then it will help with some of the diseases. And then just looking at another picture here, we have the placement of the heart within the chest. It's surrounded by the lungs, and then the lungs are surrounded by the ribs. We have different layers of the heart. So we have the endocardium, that's our inner layer. We have the myocardium, and then we have epicardium or visceral, and then we have pericardial. We'll talk about inflammatory problems next week, where there's inflammation in the endocardium or there's fluid buildup in the pericardium or pericardial area. So we're focusing on the conduction system right now in EKGs. So the electrical conduction system, the heart starts with the SA node, and then it goes to the AV node, the bundle, the right and left bundle branches, and then down to the Purkinje fibers. When we have a heart rate that initiates with the SA node like it should, then it's usually within 60 to 100 beats per minute. The further down on the pathway, the electrical conduction pathway, the slower things get. So if we're initiating a heartbeat that's lower down, like the AV node, then we're going to see something significantly slower than normal. So knowing a little bit about how that works will be helpful and how it's supposed to show or start in a certain manner and then kind of follow through. And then looking at our EKG rhythms, we are going to be looking at our P wave, QRS, and then our QT interval. Some patients might have a U wave too. So depolarization, movement of ions before contraction that facilitates cardiac contraction. Repolarization is the movement of ions back to the resting state. Our P wave corresponds with atrial depolarization. The impulse from the SA node through the atrial produces contraction. And then we have a PR interval, reflects the time required for atrial depolarization and the delay. QRS complex reflects the delay at the AV node and its ventricular depolarization. And then ventricular contraction occurs after the QRS complex in the ST segment. QRS interval reflects the time required for ventricular depolarization. T wave corresponds with ventricular repolarization. So that's a little bit about what's happening on the EKG. That is something that you do want to know for testing purposes, is what those waveforms indicate. You do not have to measure, so we're not going to ask you questions in this class specifically about what is the PR interval or what is the QRS interval or what is the QT interval. That would be later on, and usually that's also something you learn in your EKG classes that they'll have you take if you're going to work on a cardiac floor. So blood pressure we've talked quite a bit about. We have systolic, we have diastolic. We know that systole is contraction, that diastole is our relaxation. So it's important for our blood pressure to be regulated so that we have time for relaxation, we have time for filling, and then we have time and strength to eject that blood out. That blood pressure represents the force exerted against the vessel wall by blood flow. We know that there's lots of factors that can affect blood pressure. So volume, resistance, cardiac output. So different things that we've talked about in our other classes and in the first week of cardiac. So cardiac output, that's heart rate times stroke volume. And then heart rate, cardiac contractions per minute, stroke volume, the amount of blood ejected with each ventricular contraction. These terms are good to know too. So what is preload? The amount of blood at the ventricles at the end of diastole. We have afterload, the resistance to the flow the ventricle must overcome to open the valves to eject its content. And then if we have increased afterload, then we're going to have increased workload of the heart. And then contractility, the force of mechanical contraction. We can change contractility, we can change preload, we can change afterload. We've kind of talked about those in some of our other classes, preload being volume, so we can add or take away volume, afterload being resistance. So we can constrict, we can dilate, contractility, the force of contraction, and that can be affected by different medications too, or different processes. When we're talking about EKGs, we're typically talking about a 3 or 5 lead EKG where it's giving us a continuous cardiac monitoring. We can do 12 lead EKGs where it's giving us kind of like a snapshot, because you have all these different leads on your patient. They can't really move around and stuff like that with a 12 lead, but it's telling us what's happening right now. So say your patient's having chest pain, then they would want a 12 lead EKG because then we can have a better view of what's going on. It just gives more leads in a 12 lead EKG, and where we can have more information about what's happening with the heart. But if your patient's just having surgery or on a telefloor, then they would have the 3 or the 5 leads that are shown in the pictures. And then looking at the EKG graph paper, we can look at this and figure out what a patient's heart rate is. Usually one strip is 6 seconds. And so if you look off to the graph paper off to the side, it says 3 seconds is 15 large boxes. So when we're looking at patients' rhythms, usually we see a 6-second strip, so 2 3-second areas. And then we can measure that out. We can count the QRS complexes within that time frame and multiply it times 10 to get a heart rate. Our computer systems will tell us that information, so that will already be given to you. So if you're looking at EKG strips at clinical, which I highly recommend that you do, then you will have either a print off or you'll look at it on the computer and it'll give you a certain amount of time, 6 seconds, and then you can review the rhythm. So across the bottom, it measures time in seconds. Vertical measures amplitude, and each little box is 1 mm. So things that we look at when we're measuring rhythm, so our PR interval, time measure to depolarize the atria and travel to the ventricles, QRS interval, the measure of time to depolarize the ventricles, QT, the measure of time it takes for the ventricle to depolarize and then repolarize. As I said earlier, you don't have to know those specific numbers, so you don't have to know that a PR interval should be less than 0.20 or the QRS should be 0.12 or anything like that. That will be a later thing where you have to know those specific intervals. But right now, we're going to have you look at what is the heart rate? Is it fast or is it slow? And then if there's any abnormalities. And so we'll get into more specific pictures. So when we're looking at EKGs, is it slow? So less than 60, is it 60 to 100, or is it greater than 100? So is it fast, slow, regular? Is it regular or irregular? So we should have a P wave for every QRS, then we should have that QT interval too. So do we have P waves? Do we have QRS complexes? Are there T waves? The intervals being normal limits, that's measuring, that will be later on. So looking at that 6-second strip, which is what we have here, you see those little arrows across the top. So from one arrow to the little next arrow, that would be 3 seconds to the next arrow. That would, if you looked at all 3 arrows combined, that would be 6-second strip. So then they go across the bottom and say that we're measuring our QRs, we're counting our QRs, and then we're multiplying times 10 to get what is the heart rate per minute. And then marching out the waveforms, like we said, there should be a P wave with every QRS. And then our QRS interval should be pretty even across. So that one picture off to the side, you can see they look pretty regular and even across. So if we had calipers, we could put one end of the caliper on the QRS and then put the other part of the caliper onto the next part of the QRS and measure that across, and they should be even. So if you look to the rhythm off to the side, you can see that maybe we were pretty even to start with, and then we had some irregular beats, and we had a fast beat, so we saw some changes. So we would be irregular. So rhythms can appear irregular if we have, maybe some PVCs or PACs, and we have some abnormal beats. We will see irregular rhythms with AFib. So here we're looking at a rhythm that is normal sinus rhythm. So looking at our first QRS, our first complex, we see a P wave, then we see that upward spike and a downward spike, that's our QS, and then we see another waveform, and that's our T. And so we should have a P, a QRS, and then we should have that T interval. If we count the QRS complexes, 1, 2, 3, 4, 5, 6, 7, 7 times 10 would be 70. We would, of course, look at our patient and make sure that they're tolerating this rhythm, that they're not short of breath, they're not diaphoretic, they're not pale, they're not anything like that that would tell us that maybe they're not tolerating this heart rate. So always look at your patient, always confirm that there's a pulse, make sure that your patient is feeling okay. There is something called pulseless electrical activity, and that's where there is electrical activity on the EKG, but we're not seeing a pulse, we're not having muscular contraction, mechanical contraction, movement of blood flow. And so if you're ever questioning your patient, if they're not talking to you or anything like that, you would always want to check a pulse and confirm. So when we have dysrhythmias, we have disruptions in our cardiac conduction pathway, deviations from normal rate or rhythms, things that patients might complain about: shortness of breath, diaphoresis, hypotension, palpitations, syncope. Here we have a slower heart rate. So we have a heart rate less than 60. This is supposed to be a 6-second strip-ish. We only have 2 of the little arrows though. Counting what we have right now, 1, 2, 3, 4. It would be nice if it was a little more even. So we have a slower heart rate. So a heart rate less than 60. This is supposed to be showing a heart rate about 40. So when we have patients that are like athletes or runners, they might run a little bit slower on their heart rate because they've been really conditioned. Most patients, if they're not athletes, really might not tolerate a heart rate in the 40s. So always checking your patient, asking them what is normal, what is abnormal for them, are they stable or unstable. So with this can occur with low temperature, so hypothermia. So our patients out in Wisconsin that I've taken care of, fall through the ice in winter in that really cold environment. They come in really Brady. And so we can see sinus Brady with, low temperatures. We can see sinus Brady with hypoxia. So we can see this with other problems. You always want to check, like I said, check a pulse, check a blood pressure, assess your patient, see how they're feeling. So your patient's heart rate might be 40 or 45 and they feel okay, and maybe that's normal for them because they exercise a lot. Me, I don't think I've ever seen 40, and I probably would not feel very good with 40. And so, were they passing out? Were they short of breath? Were they sweating? Did they turn gray? Are they symptomatic or not symptomatic? And if they're symptomatic, then we got to do something to fix their heart rate. So we can have the pacing. So we could put the transcutaneous pacing patches on your patient. A medication that we can give is atropine. We've talked about atropine before. It's an anticholinergic medication. We talked about it for drying of secretions. It increases your heart rate too. So atropine can be given IV for these patients to increase their heart rate if they're symptomatic. Sinus tach, there's reasons that we can have a heart rate greater than 100. So hypovolemia, so we're lacking volume, our blood pressure is low. If we've had a pulmonary embolism, if we have MI, caffeine, stimulants, illicit drugs, things like that can all make us have a faster heart rate. Fever, and then anemia. So we mentioned with anemia that they are lacking the red blood cells or lacking hemoglobin, lacking something, and so they're not oxygenating and perfusing well because they're missing some of that component. So your body decides to increase the heart rate to try to move around what it does have. So we can see tachycardia with anemia. Fever, also like a higher metabolic state, so we can see that increase in heart rate. You want to ask your patient what's their normal range, how are they feeling, assess your patient. So see how their blood pressure is, are they short of breath, do they feel like they're going to pass out or anything like that. So we want to try to treat the underlying cause. So if we see someone that's tachycardic and they're coming in a dehydrated state, we're going to give them fluids. If they're hypotensive, kind of the same thing. Do we need fluids to increase their blood pressure? If it's fever related, we'll probably give some fluids and then look at let's get the temperature decreased. If it's stimulation, how long ago has it been since we took caffeine or any sort of stimulant? And then pulmonary embolism, you would probably see an increase in respiratory rate in the same time. You would see or, have maybe a recent DVT, you'd have some other symptoms so that they would consider that it was a PE. And then try to treat the underlying cause. So like I said, if it's fever, try to treat the fever. If it's volume, give them volume. If it's hypotension, try to correct their blood pressure after fluids. If it's related to an MI, do they need to go to the cath lab and things like that. And then we can give beta blockers to help decrease this heart rate. Beta blockers are amazing for a whole bunch of stuff. We said that they're good for hypertension, decreases our sympathetic nervous system, reaction response, and so they can have beta blockers, metoprolol, labetalol, all those ones that end in LOL. They can be given IV to slow the patient's heart rate down. And then patients can also have calcium channel blockers that can help with tachycardia too. And we had said with beta blockers, we always want to check the heart rate and the blood pressure. So we're not going to jump like to a beta blocker if your patient's blood pressure is low. That wouldn't make sense. So, and then SVT, this one's a little bit interesting. So this is a fast heart rate. It's typically greater than 180, 170s, 180s. And then you can't really see the P waves. So if we go back, so if you look at the previous slide in sinus tach, we still saw P waves, we saw QRSs, we had that T. So at the very top, you can see we have a P wave, QRS, and then a T, P wave, QRS, T, P wave, QRS, and then it starts to all kind of smush together. And you're not able to see, like, is that a P wave or is that the QT? So what's exactly happening in the middle of that upper graph one? So it's going fast. That would be considered supraventricular tachycardia. You look at the lower one down, it's really hard to tell. Do we have P waves? Do we have that QT interval? They're all kind of blending together. So this is a narrow complex. So your Q wave, your QRS is narrow. We'll look at things that are wide in a little bit. So things that they can do for SVT, they can do vagal maneuvers, like have them bear down. The problem with SVT is the heart is working really hard. It's not going to be able to tolerate this long term. And then also it's not having time to fill and get that blood flow. And so we're going to eventually have compromise with our patients. They're going to start to feel bad. So it's important to try to decrease this heart rate. So vagal maneuvers, bearing down like you have to go to the bathroom. Sometimes they will put their faces in ice, have them blow through a straw that they're like clamping. So they'll have them do different things to try to get out of this heart rate. Adenosine is another medication that we can give to help this fast heart rate. So adenosine, it's given up to 3 times, 6 milligrams, 6 milligrams, 12 milligram times. The thing with adenosine, and we'll talk about this in Pharm 2, is it causes your patient to have sometimes a little pause, which can be scary with your patient's heart rhythm. And then we want to make sure that the crash cart is available if we're giving adenosine. Adenosine has a super short half-life, so you have to give it IV SLAM. You connect your patient's IV typically to a stopcock. So you have a flush on one side and then the med, and then you can able to really quickly get that in. Sometimes they'll have them raise the arm up above the head to get that medications quickly to the heart to try to revert or slow down this rhythm. So we'll watch a video in Pharm about adenosine. So we talked about normal, we talked about slow, we talked about fast, and then we talked about fast where your P waves are kind of blending in with your T waves, and that's SVT. So now we're going to talk about some abnormal beats or some ectoby. So in this slide, we're showing you where we have a premature beat. So we start off, we have P wave, QRS, T, P wave, QRS, P wave, QRS, T. And then if we are measuring things out, they look pretty regular. And then we have just a little bit of an early beat. And so that can be caused by premature firing. That can be related to hypoxia, excessive stimulants, infections, digitoxicity, or coronary artery disease. Typically, these are not anything to get like super excited about. If we're seeing these frequently on the monitor, or if the patient's complaining, oh, I'm having palpitations, then they're going to try to look into the causes a little bit more extensively. Like, okay, are we drinking a lot of Mountain Dew, or do we have an infection? Do we have something going on with our meds? Do we have some cardiac issues that we need to look at? With AFib, what we have is irregular there. So you don't see like one nice, pretty P wave on these slides. You see kind of like a wavering line, and so it's hard to tell, like, are there P waves? Like, what's exactly going on there? It's irregular in their rhythm. And then what happens with atrial fibrillation is our atrials are not contracting and able to like move the blood flow the way that they're supposed to, so that blood can sit there and start to clot. And patients need to be on anticoagulation therapy if they're in atrial fibrillation. Generally, we'll say that heart rate less than 100, that is more of a controlled AFib. If it's a heart rate over 100, then they might call it rapid ventricular response. They might say AFib, rapid ventricular responses. Atrial fibrillation is pretty common as we age, so we see it more likely as people are getting older. If we have hyperthyroidism, hypertension, pericarditis, which is fluid around the heart, obesity, diabetes, chronic kidney disease, and then we could see this after open heart surgery or cardiac procedures. Patients in AFib are at high risk for stroke or pulmonary embolisms due to the clots moving, and they're also at higher risk for myocardial infarction. So the goal is that we control the rate if it's fast, and then we want to prevent the patient from having clots. And so they'll be put on anticoagulation therapy. They can have a cardioversion with atrial fibrillation. That is done once they've checked to make sure there isn't clots, because if we have this atrial fibrillation, there's pooling in the atrias that can cause clotting, and then we restart your heart and get it into a regular rhythm, that clot can move elsewhere, so into your brain. So they always have to check that, and they do that with an echocardiogram. We can give different medications to help with atrial fibrillation, cardizem, amiodarone, so we'll talk about them in pharmacology. And then atrial flutter. So this is more sawtooth. So if you think of like what a saw looks like, that's what is between the QRS complexes. Once again, it's hard to tell, like, do we have good P waves? No, not really. We just have lots of sawtooth pattern. And then we can have the fluctuating heart rate. We could have rapid ventricular response where it is faster. This can be related to MI. This can be related to valve problems. This can be related to increased thyroid hormones, COPD, digoxin toxicity, open heart surgery. And then this is treated very similarly to AFib. So we want to try to control the rhythm. If it's fast, we want to slow it down. So it might be beta blockers, it might be calcium channel blockers, digoxin, and then antiarrhythmic medications that can be amio. We don't want clotting. We don't want our patients to have clots that go elsewhere in our body if they're having those irregular rhythms. So switching a little bit now, we have junctional rhythms. This is where it originates in the AV node instead of the SA node, and we wanted it to start in the SA node. So junctional rhythms tend to be slower, so rate 40 to 60, although there is accelerated junctional. And then there is junctional tach. So we either have absent P waves or we have inverted P waves, and this can be caused by dig toxicity, electrolyte imbalances, and then hypoxia too. So PVCs are when we have the ventricles that are starting the contraction earlier. They're not in sequence with the rest of our system. And so looking across here, we have a couple different versions of those PVCs. So notice how those QRS complexes are wider than the other QRS complexes. And those are telling us that it's starting in the ventricle instead of following the normal kind of pathway. So this can be caused from electrolyte imbalances. This can be MI, this can be stimulants, this can be hypertension, this can be recreational drug use. We want to try to look at and see what the cause is and try to fix it. So if it's the electrolyte imbalance, do we need to supplement something? If it's related to recreational drug use, then they'll, of course, encourage that to be stopped. If it's related to stimulants, then we'll see also stop those. Hypoxia, then we're gonna try to fix your oxygen level. And then these are lethal rhythms. So we have ventricular tachycardia, or sometimes called VTAC. This is a typically, it's going to be a situation where your patient is not going to be perfusing. They might have a pulse to start, but your heart rate can't really tolerate that. This is a very fast rhythm. So this is not going to be a good perfusing rhythm. Patients might have a pulse for a little bit. So you always want to check a pulse if you see VTAC on the monitor. And then you want to assess your patient. So if this is left untreated, this will cause your patient to pass away. And then significant reduction in the cardiac output, the blood that's being moved around when we have this really fast rhythm. This can be caused by lots of different things. So abnormal potassium levels, being acidotic, hypoxia, hypovolemia, hypoglycemia, hypothermia, toxins, cardiac tamponade, myocardial infarction, or pulmonary embolism. So in this situation, we need to go and check our patient, see if we have a pulse, call for help. If we have no pulse, then that is a code situation. We're going to start CPR, get all of our friends to help us there. And then once they bring the crash cart, defibrillation is what we do if we have pulseless VTAC. But that is part of ACLS. And then we can give, moving through the code, we would give antiarrhythmics like amiodarone. We would look at their electrolytes. They could, if they did have a pulse, they could try cardioversion. And then no pulse, we're doing CPR, we're defibrillating, we're doing the code situations. Ventricular fibrillation, another lethal rhythm, most frequent rhythm in cardiac arrest, the shaking, quivering line. We don't have good perfusion. The causes are the same as VTAC. And then we want to defibrillate. Your patient should not have a pulse with this rhythm. If they do have a pulse, like we should check the EKG monitoring and assess our patient a little bit further. But your heart is just quivering here, so the blood flow isn't going to be perfusing out to the body. The cardiac output is significantly decreased, so we wouldn't see a pulse with this. Start CPR immediately. They would want to call a code, they would want to get assistance here, and then you want to defib the VFib. I had a patient describe this once as like a restart for your system, like your computer, it's not working, it's making you mad, and you hold the button and you shut it down. So defib is like that restart, and it's going to try to get you back into a normal rhythm. Like when you turn your computer off because it's not working well, you're going to try to get it to start functioning normally again. So there's specific things when we're going to defibrillate a patient. We want to make sure that it's done as controlled as possibly. I know people get really excited during a code. We want to make sure no one's holding on to the patient. We would have a pause, hands off your patient, stop begging your patient, stop doing whatever, so that they can defibrillate, because you don't want the electrical energy transfer from the patient to anyone that's touching the patient, because we don't want a second victim. So always clear the bed, clear the room to make sure that no one's touching the patient or touching metal or anything where it could transfer. And then asystole, so no measurable electrical activity from the heart. Check your patient's leads, make sure it's connected, check your patient, see if there's a pulse. If there is nothing and we have this flat line, then you're going to start CPR. This is not a shockable rhythm. You need to have a rhythm to be able to shock it into something else. So for asystole, after we've confirmed that, we do CPR, we're going to give medications, and we're going to look at thinking about like what are the potential causes that a patient might have had. So is it, there's cardiac tamponade or something like that. So we'll try to think about the other causes and try to fix it while doing CPR, while giving epinephrine IV. So that's something that they'll focus on with asystole. So looking at our cardiac rhythm, so do they have signs that they have cardiac output? Do they have poor cardiac output? We want to identify the rhythm, so knowing what sinus rhythm looks like, sinus brady, sinus tach. What are our atrial rhythms, atrial fib, atrial flutter, our fast rhythms, so SVT, VTAC, VFib, asystole. Junctional is a really tough one because there is 3 different kind of types like accelerated, inverted P waves and things like that, understand that junctional has some abnormal things and it's often related to like DIG toxicity. DIG, as you saw, was a potential to cause some of these dysrhythmias. It's a great medication, but it comes with some risks. So if your patient's on digoxin, need to monitor their cardiac system and be aware. Is your patient symptomatic? Is your patient asymptomatic? So like I said, is your patient's heart rate slow? How are they tolerating it? Check a blood pressure, check vital signs. Is your patient's heart rate fast? Once again, how are they feeling? How are they tolerating it? Is their blood pressure okay? Do they look normally? And then looking at, of course, having your EKG monitoring. Do we have an order for an antiarrhythmic? Be prepared to start CPR or do ACLS, document any occurrences of dysrhythmias. And then just a couple other things. So transcutaneous pacing or pacemakers, they can pace heart rates that are low, like patients that are symptomatic bradycardic. So just looking at where they would put the patches or the paddles to pace your patient. They can also have an implanted pacemaker for patients that are at risk for sudden cardiac death, patients that have heart failure and low ejection fraction. They can implant that pacemaker. People that are aging can have a pacemaker if their SA node isn't working. And then it should give us a pacer spike, which is shown at the bottom picture graph, if it's working correctly. And then patient education, report any chest pain or discomfort. Make sure to take your anti-dysrhythmic medication as prescribed. Recognize any complications. And then we'll watch the dysrhythmia video in class. We have a case study, and then we have a couple questions at the end. So this is just a little introduction to EKGs. We'll have a paper printout of different rhythms for you to look at and identify too.